Hello, thank you for having me today. Oh, okay. Thank you. We have no disclosures. Informed consent is a core component of ethical care and is instrumental in preparing patients for potential surgical outcomes. Many studies have demonstrated a concerning deficit of knowledge by patients giving operative consent, and this raises the question of how informed patients actually are when they give consent and what, if anything, can be done to improve patients' understanding of their surgeries. Many other studies have investigated the use of video to improve patient knowledge prior to surgery with positive outcomes, but little has been done to investigate this specifically for common general surgery procedures, the kinds we do every day. The objective was to assess whether a fully illustrated standardized video consent would improve patient knowledge and satisfaction compared to our standard non-video consent. This was a randomized study conducted at 2 CHI hospitals in Omaha, Nebraska, and involved 118 patients. We created comprehensive video surgical consents for each of the following operations: appendectomy, cholecystectomy, hiatal hernia repair with fundoplication, and inguinal hernia repair. And on the right, I give an example of some of the illustrations I actually made myself for these video consents. We excluded patients unable to consent for themselves. This included patients that were minors, which is under the age of 19 in the state of Nebraska, and those who were not fluent in English. We created tests of knowledge for each of the procedures, one example of which is on the right, and we utilized a CSQ-8 patient satisfaction survey. Patients were then randomized by flip of a coin to the video consent versus the standard consent group. This is the workflow for this study. We started with the patients by getting informed consent for participation in the study and release of information. They were randomized, and then they did a pre-test of knowledge for the procedure. They then underwent the consent process, either standard or video, and then had a post-test of knowledge, which was identical to the pre-test. We then gave them the first satisfaction survey, and they had their surgery with hospital stay for most of them, if applicable. And then following discharge, usually either at their postoperative checkup visit or if we weren't able to reach them then over a phone call, we administered another satisfaction survey. And just to clarify for those not familiar with a CSQ-8 it's a satisfaction survey asking them about their overall hospital stay. It didn't actually have any questions regarding the consent process. Our demographics are shown here. The main thing of note is, despite randomization, we did have a statistically significant difference in terms of biologic sex. Not sure why that occurred, and also not sure if that would have had any effect on our results, but wanted to point it out to you all. And then in terms of results, there was a statistically significant difference in the pre- and post-consent knowledge scores between the video and the standard consent groups, with an improvement in the video consent group. But this significance was only seen for patients consented in the clinic setting, not in the emergency department. This is the graphs for those. And then there was no statistically significant difference in patient-reported satisfaction between the video and the standard consent group immediately after consent or following discharge. Limitations of our study: insufficient power. We had a lot more patients in the clinic setting that were consented versus the emergency room setting, which might be one reason why that wasn't as statistically significant. There's also significant confounding variables, particularly with patient satisfaction over an entire hospital stay. There are many write-in comments on some of our satisfaction surveys that were offered to them post-surgery, and there was lots of comments on, had to wait a long time for a nurse to help me to the bathroom, or, had an adverse experience in the emergency room. None of them actually mentioned the consent process at all. And then, like all the other studies we looked at when researching this study, these were non-validated patient knowledge surveys, and we are not professional survey makers, so that could possibly add some bias. And then there were only 2 institutions involved within a single city, so limited generalizability, and we excluded non-English speakers. So at least in the clinic setting, there was an increase in patient knowledge about the procedures with the video consent. This suggests that patients were better informed about their procedures with the video consent, which I think we would all agree is a win. The lack of statistical significance in the emergency room group may have been a power issue. There was half as many patients in this group versus the clinic group. But as we all know, being in the emergency room with an acute surgical issue is a stressful situation. And one thing many studies have shown is that people have less retention of knowledge when they have high cortisol levels and all of that. So that could have also influenced that. And then there was also no statistically significant difference in patient satisfaction at the time of consent or post-discharge. The satisfaction data did seem to have a trend toward, and this is kind of worded strangely, but less decline in post-discharge satisfaction. Pretty much, all of our data showed that people were less satisfied in the, post-operative survey than when 2 weeks out, but there was a trend toward less dissatisfaction in the video group. So maybe if we had had more power, we would have been able to lay that out better. These are my references, and I'd be happy to take any questions.